Welcome back to the deep dive. Today, we're tackling something really critical. We're going deep into how the central nervous system, well, how it fails.
Yeah, exactly. We pulled together some pretty rigorous medical sources.
Right. Looking at everything from, those sudden catastrophic events like stroke or trauma,
hmm
all the way through to the really specific drug treatments for chronic stuff like Parkinson's.
And our focus, really, it's the pathopharmacology. We want to get beyond just listing
Oh,
symptoms.
okay.
We're tracing the actual chain reactions, the molecular steps that lead to injury.
So why things go wrong at the cellular level?
Precisely. And then how specific things we do, whether it's like cooling the body or using very targeted drugs, how those interventions actually interrupt those damaging processes.
Understanding the brain's balance and how we try to restore it. It's about the why behind the treatments.
That's the mission today.
Okay, so let's kick off with the absolute basics for brain survival, energy. And first, we need to nail down two terms that often get mixed up, hypoxia and ischemia.
Yeah, that's super important because they damage the brain differently. Hypoxia,
Mm.
that's oxygen deprivation. But crucially, blood flow is still happening.
Right, like with severe anemia, maybe, or carbon monoxide poisoning.
Exactly. The blood's getting there, but it just can't carry enough oxygen, or the oxygen can't be used. It tends to cause more of a global shutdown, drowsiness, confusion,
Okay.
maybe seizures eventually.
But ischemia, that's the blood flow itself being cut off.
Yeah.
And that sounds much worse for brain tissue.
Oh, absolutely.
Right.
Ischemia is the killer. Reduced or totally interrupted blood flow means no oxygen and no glucose.
Mm.
And the brain burns through energy like
Yeah.
crazy. It has almost no reserves.
And that can be focal, like in one spot during a stroke.
Just one region affected.
Or it can be global, like after cardiac arrest, where the whole brain isn't getting enough blood.
Right. Total inadequate perfusion everywhere.
And the sources we looked at are honestly terrifying about how fast things go wrong in global ischemia. That window is incredibly small.
It is shockingly small. The brain's glucose reserve, gone in maybe 2 to 4 minutes.
2 to 4 minutes, wow.
And ATP, the actual energy currency, depleted in about 4 to 5 minutes.
So 5 minutes without blood flow and the energy's basically gone.
Pretty much. Aerobic metabolism just stops. And the whole system starts to crash because the machinery keeping the cells alive runs out of fuel.
And the critical piece of that machinery is the sodium-potassium pump, right? The Na plus K plus ATPase.
That's the linchpin. It's the single biggest failure point initially. Its whole job is pumping sodium out and potassium in, using ATP, nonstop work.
to keep that electrical balance across the cell membrane.
Exactly.
Yeah.
But when the ATP runs out, the pump just stalls. Sodium floods into the cell,
And water follows sodium.
always.
Mhm.
Osmosis. So water rushes in, the cell swells up massively, that's cytotoxic edema, and eventually it just bursts.
Weiss.
Yes, an osmotic explosion inside the cell. But wait, there's more damage happening at the same time, something chemical. Yes, because the body gets desperate. It switches to anaerobic metabolism, trying to squeeze out any energy it can without oxygen.
But that's really inefficient, isn't it?
Slightly inefficient.
Right.
And the waste product is lactic acid, lots of it, very quickly.
So the pH drops, acidosis.
Right, severe acidosis.
Yeah.
And that acid basically corrodes everything inside the cell, proteins, structures.
Hmm.
It's chemical damage on top of the swelling. A double whammy.
Okay, so given that catastrophic cascade, the immediate treatment for global ischemia has to hit all those points, right? Reverse them somehow.
That's the goal. After you get circulation back, of course.
Right. What's the most vital thing then?
One of the absolute most critical interventions is therapeutic hypothermia, cooling the patient.
Why cooling?
Because by lowering the body temperature, usually down to around 32, 34 degrees Celsius, you drastically cut the brain's metabolic rate.
You're slowing everything down.
Exactly. Forcing those struggling cells to demand less oxygen, generate less ATP, and crucially produce less lactic acid. It minimizes the acidosis. It buys you critical time.
Makes sense. And beyond cooling, you need to fix the physical environment too.
Absolutely. Aggressive hemodynamic support is key. That means getting blood volume back to normovolemia, and maintaining normal blood pressure. You need that pressure to push blood back into the brain.
To restore perfusion. We'll get to CPP later, I guess.
We will. And of course, respiratory support. Maximum is the oxygen available in the blood that is getting there. Ventilation, oxygen.
Got it. And you mentioned blood sugar earlier. Why is keeping glucose around, say, 140 so important right then?
Because both extremes are really bad news in this situation. Too low, hypoglycemia, and the brain starves even faster. ATP depletion accelerates.
Okay.
But too high hyperglycemia actually fuels that damaging anaerobic metabolism. It makes lactic acidosis much, much worse. So you end up causing more secondary chemical injury.
So tight glucose control is non-negotiable.
Essential part of damage control after that initial hit.
Okay, so if the energy crisis causes the immediate cell death, the secondary injury that follows often dictates the long-term outcome. And a huge player there is something called excitotoxicity.
Right. This is where the brain kind of turns on itself, using one of its most vital signaling molecules as a weapon.
And that molecule is glutamate.
Glutamate, yeah, it's the main excitatory neurotransmitter.
Yeah.
Absolutely essential for memory, learning, movement. Normal brain function depends on it.
But what happens when cells get damaged, say, in a stroke or from trauma?
Those damaged or dying cells just leak massive amounts of glutamate out into the synapse, way more than normal. It floods the system.
And that flood overwhelms the receptors.
Exactly. It causes uncontrolled activation of the NMDA receptor, which is a key glutamate receptor. Think of it like a gate.
Okay.
Normally, glutamate opens a gate briefly. But this massive flood props the gate wide open, keeps it open, and that allows a huge, unregulated torrent of ions into the neuron.
Mainly calcium and sodium.
Primarily calcium. And that massive influx of calcium is what's really toxic.
Right, the calcium cascade. How does too much calcium actually kill the cell?
Well, that excess intercellular calcium acts like an executioner. It activates a whole bunch of destructive enzymes that are normally kept switched off.
Like what kind of enzymes?
We're talking proteases that chew up proteins, lipases, specifically phospholipases that destroy the cell membrane itself, and endonucleases that chop up the cell's DNA.
Wow. So it's just complete internal demolition.
Pretty much. Total breakdown of structure, plus it triggers massive free radical formation. It's a self-destruct sequence that can spread the damage well beyond the initial injury zone.
So the idea behind neuroprotectant drugs is to stop that self-destruction.
Precisely. They're like molecular fire extinguishers.
Yeah.
They don't fix the initial hit, but they try to block that NMDA receptor overactivation or interfere with the downstream steps in that calcium cascade.
To try and save that surrounding tissue, the penumbra we mentioned.
Exactly. Reduce the secondary injury, save as much salvageable brain as possible.
Okay, shifting from the molecular to the mechanical. The skull is a closed box, right? So increased intracranial pressure, ICP, is a huge physical threat.
It is. The Monro-Kelly doctrine basically says volume of brain tissue, blood, and cerebrospinal fluid, CSF, are balanced inside the skull. If one goes up, say, due to swelling,
Like edema.
right, or a bleed, then something else has to decrease, like CSF or venous blood volume,
Yeah.
to keep the pressure normal. When that compensation fails, ICP starts to rise.
And the key number we watch is cerebral perfusion pressure, CPP.
Yes, CPP tells you if blood can actually get into the brain against that intracranial pressure, it's simply mean arterial pressure minus ICP.
So CPP equals MFP ICP.
Correct. Normal ICP is low, like 5 to 15 millimeters of mercury. But if the CPP drops below 50, that's critical. It signals brain ischemia is happening right then because the pressure is too high for blood to flow properly.
It's literally squeezing the blood supply shut.
Effectively, yes.
So what's the very first sign we need to look for? The most reliable indicator that ICP is going up.
The earliest and most reliable clinical sign is a decrease in the patient's level of consciousness, LOC.
It's becoming less responsive, less awake.
Exactly. Confusion, lethargy, drowsiness. It happens often before any dramatic physical signs appear. It's your first warning bell.
And if the pressure keeps rising, eventually it affects the brainstem and triggers that Cushing reflex.
Yeah, Cushing's triad. Technically, it's a very late, very bad sign. It means the brainstem itself is becoming ischemic and herniation might be imminent.
And the triad is?
It's hypertension. The body jacks up blood pressure, desperately trying to force blood into the brain. Then reflex bradycardia, a slow heart rate, because sensors detect the high systemic pressure. And finally, a widening pulse pressure, a big gap between systolic and diastolic numbers.
So high BP, low heart rate, wide pulse pressure, ominous.
Extremely ominous. Indicates critical ICP.
And after the LOC changes, and maybe Cushing's, the neurological signs progress in a pattern.
They do. Typically, LOC changes first, then pupils might change, become unequal or fixed and dilated. Then you might see posturing.
Decorticate or decerebrate?
Right. Decorticate is flexing inward towards the core. Decerebrate is extending outwards. Both indicate severe brain injury. And finally, you get abnormal respiratory patterns as the brainstem centers fail.
And if the pressure isn't relieved, the brain tissue itself starts to shift, to herniate.
Exactly. It gets squeezed out of its normal compartment through openings like the tentorial notch or under the falx cerebri.
And different herniation patterns cause specific problems.
They do. Like cingulate herniation under the falx might compress the anterior cerebral artery, causing leg weakness.
Okay.
Central transtentorial herniation pushes the diencephalon down, causing deep coma and that decorticate posturing.
And the really dangerous one, uncle.
Uncal transtentorial herniation is often the most rapidly fatal. The uncas, part of the temporal lobe, squeezes through the tentorial notch. It compresses the oculomotor nerve, causing that classic blown pupil on one side, hits visual pathways, and quickly compresses the midbrain, leading to respiratory arrest. Very bad.
Let's talk about the swelling itself, the cerebral edema. Two main types, vasogenic and cytotoxic.
Right. Vasogenic means leaky vessels. The blood-brain barrier gets damaged by a tumor, infection, trauma, and fluid, and proteins leak out from the blood vessels into the extracellular space around the cells.
Mostly in the white matter.
Mostly white matter, yeah. It acts like a mass, pushes things around, can displace whole hemispheres. It's common with tumors and abscesses.
And cytotoxic edema, that goes back to the cell failure we discussed.
Exactly. Cytotoxic means toxic to the cell. This is the actual swelling of the brain cells themselves, usually because that Na plus K plus pump failed during ischemia, or maybe from something like water intoxication causing a hypoosmolar state.
So the cell itself fills with water and swells.
Right. The BBB might be intact, but the cell's internal environment is overwhelmed. Leads to lysis, worsens acidosis. It compounds the initial injury.
And how do we treat these different types of edema?
Well, for vasogenic edema, especially from localized things like tumors, glucocorticoids, steroids can work really well. They help stabilize that leaky blood-brain barrier.
Okay.
But for acute severe edema, either type really, we often need osmotherapy, using drugs like mannitol or hypertonic saline.
How do they work?
They make the blood much more concentrated, osmotically speaking. They create a gradient that literally pulls excess water out of the brain tissue and back into the bloodstream to be excreted by the kidneys. It rapidly reduces intracranial volume.
Okay, let's shift to physical trauma. Traumatic brain injury, TBI. You have the initial hit, the primary injury.
Right, the direct damage from the impact, the bruise, contusion, the cut, laceration, the immediate bleeding hemorrhage, that damage is done, irreversible.
And then everything that happens after is secondary injury.
Exactly. The edema, the rising ICP, maybe infection sets in, or hypoxia from breathing problems. That's what we try to prevent or treat aggressively.
Yeah.
Because secondary injury can make the outcome much worse.
And with contusions, you get those coup and contre-coup injuries.
Yeah. Coup is the bruise right under where the impact happened.
Okay.
Contre-coup is when the brain bounces off that impact site and hits the opposite side of the skull. Very common in car crashes or shaken baby syndrome. Often causes more diffuse damage, especially front and temporal lobes.
Now, the bleeding inside the skull, the hematomas. Location is everything, right?
Right.
Let's start with the really fast one, epidural hematoma.
Epidural means above the dura, between the dura mater and the skull. And critically, it's usually an arterial bleed, often from the middle meningeal artery getting torn, frequently with a skull fracture.
Arterial means high pressure, fast bleeding.
Extremely fast. Yeah. Builds pressure rapidly. The classic story, though not always present, is the lucid interval.
Right. The head injury, brief unconsciousness, they wake up, seem okay for a bit.
Maybe an hour or two.
And then crash hard as the pressure skyrockets.
Exactly. Signs often include a pupil dilating on the same side as the bleed and weakness on the opposite side of the body, contralateral hemiparesis. It's a surgical emergency, but if caught fast, outcomes can be good because it's usually localized.
Okay, contrast that with a subdural hematoma.
Subdural is below the dura, between the dura and the arachnoid layer. This is usually caused by tearing of bridging veins that cross that space.
Venous bleeding, slower.
Much slower. Lower pressure, so the blood collects more gradually. We talk about acute subdurals within 48 hours, subacute maybe up to 2 weeks.
And chronic subdurals.
Yeah, those can show up weeks or even months after a minor head bump, especially in older adults or people on blood thinners. The fall might be forgotten, and they present with vague stuff like headache, confusion, maybe trouble walking. Insidious, but still needs treatment.
Okay, now on to strokes. Cerebrovascular disease. Huge numbers, leading cause of disability.
Massive public health issue. Around 800,000 a year in the U.S.
Right.
And the vast majority, almost 80%, are ischemic, blocked blood flow.
Right. And those ischemic strokes can be thrombotic.
where a clot forms right there, usually on top of existing plaque, atherosclerosis,
Or embolic.
where a clot travels from somewhere else, often the heart, like with atrial fibrillation, or maybe from the carotid arteries and lodges in a brain vessel.
And lacunar strokes.
Those are tiny strokes in the very small, deep, penetrating arteries. Can cause significant deficits depending on location.
The key concept for treating acute ischemic stroke is the ischemic penumbra. Why is that so critical?
The penumbra it's the salvageable brain tissue. It's the area surrounding the core of dead tissue, the infarct.
Okay.
In the penumbra, blood flow is severely reduced, so the cells aren't functioning.
Yeah.
They're electrically silent, but they're not dead yet. They're just stunned, hanging on.
So there's a chance to save them.
Exactly. But that window is closing fast. Every minute that goes by, more of that penumbra dies and becomes part of the core infarct. The secondary injury cascades, like excitotoxicity, are actively spreading into it.
So time is brain, literally.
Absolutely. The goal of acute treatment, like thrombolysis, is to restore blood flow before the penumbra dies.
And sometimes the body gives a warning shot, a TIA.
A transient ischemic attack, basically a mini-stroke. Temporary symptoms, weakness, numbness, speech trouble that resolve completely, usually within minutes to an hour.
That's not benign.
Not at all. It's a
Right.
huge warning sign. The risk of having a full stroke after a TIA is really high, like 10–15% within 3 months. And critically, about half of those subsequent strokes happen within the first 48 hours after the TIA.
So a TIA needs immediate workup.
Urgently. Treat it like the emergency it is.
Now, the other 13% or so of strokes are hemorrhagic, bleeding.
Right. Bleeding into the brain tissue itself, intracerebral hemorrhage, or into the spaces around it. These often have a much higher mortality rate than ischemic strokes.
What causes them typically?
Often it's the rupture of small arteries damaged by chronic high blood pressure. Or it could be a ruptured aneurysm or an AVM, which we'll get to. Classic symptoms are sudden, severe thunderclap headache, often with vomiting, and rapid decline.
Okay, let's touch on subarachnoid hemorrhage, SAH, usually from an aneurysm rupture.
Yes, bleeding into that subarachnoid space where the CSF circulates. Sometimes people get warning signs, sentinel headaches, days or weeks before the big rupture, atypical headaches, maybe nausea, dizziness,
And after the rupture,
severe headache, often described as worst headache of life, stiff neck because the blood irritates the meninges, sensitivity to light, photophobia, and altered consciousness, a real neurological emergency.
and arteriovenous malformations, AVM.
Those are weird tangles of arteries connected directly to veins, skipping the normal capillary bed. Creates a high-pressure to low-pressure shunt.
Tweaking rupture more likely.
Much more likely. Plus, it can steal blood flow from the surrounding healthy brain tissue, causing ischemia-like symptoms or seizures even before it bleeds. People might present with headaches or progressive neurological problems.
So, with stroke symptoms, immediate action is key. The BE FAST acronym.
Crucial for public awareness and first responders. Balance, sudden loss of balance. Eyes, vision changes. Face drooping on one side. Arms, legs, weakness or numbness. Speech difficulty speaking or understanding. And time to call 911 immediately.
And treatment depends entirely on knowing when symptoms started and whether it's a clot or a bleed.
Absolutely. You need imaging, usually a CT scan, right away. Because thrombolytics, the clot-busting drugs like TPA, are only for ischemic strokes and only within a very strict time window, usually 4.5 hours from last known well. Giving TPA during a hemorrhagic stroke would be catastrophic.
Okay, moving from physical forces to invaders, infections.
Yeah.
Let's start with meningitis inflammation of the meninges, the brain's covering, and the CSF.
Right. And because the CSF flows everywhere on the brain and spinal cord, meningitis can spread incredibly fast. It often causes systemic illness, too.
What usually causes it?
It varies. Bacterial meningitis is often more severe.
Hmm.
Common culprits are pneumococcus, meningococcus,
Mhm.
and newborns group B strep is a big one. Viral meningitis is also common, often less severe, caused by things like enteroviruses or herpes simplex.
And the classic signs point to that meningeal irritation.
Exactly. The triad you look for is severe headache, high fever, and neutral rigidity, a really stiff neck.
Yep.
Often with photophobia, light sensitivity, nausea, vomiting. And as it progresses, altered level of consciousness.
And those specific physical exam signs, Kernig's and Brzezinski's.
Yeah, they test for meningeal irritation, Kernig's sign.
Mm-hmm.
You flex the hip and knee, then try to straighten the knee resistance, and pain in the hamstring means it's positive,
Okay.
Brzezinski sign. When you passively flex the patient's neck forward, their hips and knees automatically flex up involuntarily, Both suggest inflamed meninges.
And distinct from that is encephalitis, which is infection of the brain tissue itself.
Right. Encephalitis means inflammation of the brain parenchyma. This is generally more dangerous because the functional tissue is directly involved.
What happens in the brain?
You can get necrotizing hemorrhage, bleeding within the tissue, nerve cell death, widespread swelling. In the U.S., common viral causes are herpes simplex, which has a nasty habit of affecting the temporal lobes, and West Nile virus.
And the symptoms reflect that deeper brain involvement.
Definitely. Fever, headache, often stiff neck too, but more pronounced signs like severe disorientation, personality changes, seizures, movement disorders, and rapid progression towards coma. Much more direct neurological attack.
All right, let's talk about growth, CNS tumors. How are they generally classified?
Primarily by the cell type they originate from. So you have tumors arising from the neuroepithelial tissue itself, the neurons, or more commonly the glial cells,
The support cells?
right? The astrocytes, oligodendrocytes. Or tumors can arise from structures around the brain tissue, like the meninges, pituitary gland, cranial nerves, and then, of course, metastatic tumors that spread to the brain from elsewhere.
And those glial tumors are the most common primary type.
Yeah, about 80% of primary brain tumors are gliomas. Astrocytomas and oligodendrogliomas are major types. And the most aggressive, most infamous, is glioblastoma multiforme, or GBM.
What makes GBM so bad?
It's highly malignant, grows very fast, infiltrates diffusely into surrounding brain tissue, making complete removal impossible. It's very vascular and notoriously resistant to treatment. Prognosis is, unfortunately, quite poor.
What about other common types? Meningiomas.
Meningiomas grow from the meninges, the brain coverings. They're usually slow-growing, often technically benign, but they can get very large, compressed vital structures and can be very vascular, making surgery challenging.
Okay. And primary CNS lymphomas.
PCN and SL. These are lymphomas that start in the CNS, often deep within the brain, more common in immunocompromised people, sometimes linked to Epstein-Barr virus. They're malignant and tend to recur even after initial treatment.
And how do these tumors typically show up? Does it circle back to that pressure issue?
Often, yes. The tumor itself takes up space, causes edema around it, so you get signs of increased ICP, headache that's often worse in the morning, nausea, vomiting, sometimes seizures if the tumor irritates the cortex.
And focal signs, depending on location.
It's exactly weakness in an arm or leg, speech problems, vision changes, personality shifts. Depends entirely on what part of the brain is being affected. Treatment is usually multimodal surgery to debulk or remove as much as possible, radiation and chemotherapy targeted to the specific tumor type.
Okay, let's shift down to the spine and peripheral nerves. A really common issue is degenerative disc disease, DDD. What does that cover?
DDD is kind of an umbrella term for the wear and tear changes in the spine. Things like vertebral slippage, which is subluxation,
Okay.
narrowing of the spinal canal itself, that's spinal stenosis,
Right.
or the classic herniated or bulging intervertebral disc.
And these all basically lead to nerve compression?
Right. They pinch or irritate the nerve roots exiting the spinal cord. That's what causes the symptom.
Sciatica.
Classic symptom, pain shooting down the back of the leg, sometimes into the foot. Also paresthesias, that numbness or tingling. And typically the pain gets worse with activity, bending, lifting, anything that loads the spine or stretches the nerve.
How is this usually managed?
We almost always start conservatively. Pain meds, anti-inflammatories, sometimes a course of oral steroids can really help calm down an inflamed nerve root. Muscle relaxers for spasms. Physical therapy is key.
And surgery is reserved for.
Cases that don't respond to conservative treatment after a good trial, or if there's severe or progressive weakness, or signs of spinal cord compression itself, then options like discectomy, laminectomy, or fusion might be considered.
But sometimes back pain is an emergency, right? There are red flags.
Absolutely. You have to be vigilant for red flags that means something serious is going on, needing immediate attention.
Okay.
A clear history of significant trauma. Any signs of infection like fever or chills, especially in someone like an IV drug user who's at risk for a spinal epidural abscess, sudden problems with walking, gait instability, and the really big one, new onset of bowel or bladder incontinence.
Loss of control. And that points towards Cauda-Equina syndrome.
Exactly. Cauda-Equina syndrome is a true surgical emergency. It's when the nerve roots at the very bottom of the spinal canal, the cauda equina, looks like a horse's tail, gets severely compressed, often by a massive disc herniation or tumor.
What are the signs?
Severe low back pain, often pain radiating down both legs, numbness in the saddle area, perineum, buttocks, inner thighs.
Perianal numbness.
Right. And the defining feature is that loss of bowel or bladder function. You must decompress those nerves immediately, within hours if possible, to prevent permanent paralysis and loss of sphincter control.
Okay, moving to acute spinal cord injury, SCI. The way the injury happens matters a lot.
The mechanism tells you a lot about the likely pattern of injury. Hyperextension, like in a whiplash injury. Hyperflexion, bending forward too far. Axial compression, like diving into shallow water and hitting the bottom.
Crushes the vertebra.
Right? Or flexion rotation injuries, which often cause the most instability because they disrupt ligaments too.
And these can lead to specific patterns of partial cord injury.
Yes. Several classic syndromes. Central cord syndrome, often from hyperextension in older people with arthritis, damages the center of the cord most. Leads to weakness that's much worse in the arms than the legs.
Interesting. What about anterior cord syndrome?
That usually involves damage to the blood supply at the front of the cord, the anterior spinal artery. You lose motor function and pain and temperature sensation below the injury, but position sense and light touch carried in the back of the cord are often spared.
And Brown-Séquard cord syndrome, that's damage to just one half of the cord.
Exactly.
Yeah.
Hemisection of the cord. It's fascinating clinically because the motor pathways and pathways for light touch and position sense travel down on the same side,
Okay.
while the pathways for pain and temperature cross over almost immediately. You end up losing motor function, position sense, and light touch on the same side as the injury, ipsilateral. But you lose pain and temperature sensation on the opposite side, contralateral, below the injury level.
Wow, very specific pattern.
It is. Tells you exactly where the lesion is.
Immediately after a major SCI, the patient goes into spinal shock.
Yes. Spinal shock is this temporary period right after the injury where everything below the lesion just shuts down electrically. Flaccid paralysis, complete loss of reflexes, loss of muscle tone can last hours to weeks.
And if the injury is high up, like T6 or above.
Then you can also get neurogenic shock. That's part of spinal shock, but specifically refers to the loss of sympathetic tone from the brainstem. Leads to dangerously low blood pressure and slow heart rate because the body can't vasoconstrict or speed up the heart properly. Also, sometimes priapism can occur.
Okay, now for those patients with high-level SCI, T6 or above, there's a potentially lethal complication later on. Autonomic dysreflexia, what is that?
AD is. It's a critical condition. It's basically an uncontrolled, exaggerated reflex response by the autonomic nervous system to some kind of noxious or unpleasant stimulus below the level of the injury.
But the patient can't feel that stimulus normally.
Often not, or not clearly. But their spinal cord below the injury still senses it. And because the brain's normal inhibitory signals can't get down past the injury to calm things down, the reflex just goes wild. Exactly. The spinal cord triggers a massive sympathetic discharge below the injury level.
What kind of everyday things can trigger this?
The most common culprits are things related to bladder or bowel. A super full bladder, maybe from a blocked catheter, bowel impaction, constipation, even just a pressure sore, tight clothing, or an ingrown toenail below the injury level.
So walk us through that crisis cycle. The stimulus happens, then what?
Okay, stimulus below T6 sends signals up the cord. Can't reach the brain properly. Spinal cord below the injury reacts with massive vasoconstriction.
Blood pressure skyrockets.
Shoots up dangerously high, very suddenly.
Right.
Now, the baroreceptors in the neck and chest do sense this high BP, and they can signal the brainstem.
Okay.
The brainstem tries to compensate. It sends signals down to slow the heart rate, causing bradycardia. And it tries to tell the blood vessels to dilate to lower the pressure.
But the dilation signal can't get past the injury.
Right, so the vasodilation only happens above the level of the injury.
Ah, so that explains the symptoms.
Exactly. Above the injury, severe pounding headache from the high BP, flushed skin, profuse sweating. Below the injury, pale, cool skin because of the ongoing vasoconstriction.
And this is a medical emergency.
Absolutely life-threatening. That extreme hypertension can cause stroke, seizures, loss of consciousness, even death. The absolute first step is to find and remove that triggering stimulus immediately. Sit the patient up to help lower BP, loosen clothing, check the catheter, check for bowel impaction. Fix the trigger.
All right, for our final section, we're shifting from those acute injuries to the really complex, long-term pharmacological management of a chronic condition. Parkinson's disease, the whole strategy boils down to fixing an imbalance, right?
That's the core concept. Parkinson's involves the loss of dopamine-producing neurons.
Yeah.
So you have too little dopamine. But this also leads to a relative excess of acetylcholine activity.
So treatment aims to boost dopamine and block acetylcholine.
Essentially, yes. You're trying to rebalance those two neurotransmitter systems to improve motor control.
Let's start with the acetylcholine side. Anticholinergics, like benzatropine.
Right. These drugs block acetylcholine receptors. They're mainly helpful for reducing muscle rigidity and especially tremor.
Okay.
But they don't do much for the slowness of movement, the bradykinesia, which is often more disabling. And they have those classic anticholinergic side effects: dry mouth, constipation, urinary retention, and importantly, they can cause confusion, especially in older patients.
So, used carefully, maybe earlier on for tremor.
Often, yeah.
Now, the big one, the gold standard. Levodopa-carbidopa, LC.
The cornerstone of Parkinson's therapy. Levodopa is a precursor molecule that the brain can convert into dopamine.
But giving levodopa alone isn't great.
No, it's mostly broken down in the body before it even reaches the brain. You need huge doses, which cause terrible nausea, vomiting, sometimes psychiatric issues. Very little actually gets where it needs to go.
Enter carbidopa. What's its job?
Carbidopa is the essential partner. It's a decarboxylase inhibitor. It blocks the enzyme in the periphery that breaks down levodopa.
So it acts like a bodyguard for levodopa.
Kind of, yeah. It allows much more levodopa to cross the blood-brain barrier intact. This means you can use significantly lower doses of levodopa, which dramatically reduces those nasty peripheral side effects. It's a really clever pharmacological trick.
But even the combination isn't perfect. Still has side effects.
Oh, definitely. Once the dopamine levels rise in the brain, you can get significant issues like orthostatic hypotension, dizziness when standing up, risk of falls.
Yeah.
Also cardiac dysrhythmias. And over time, its effectiveness can fluctuate, leading to on-off periods or wearing off before the next dose.
Which is why doctors often try to delay starting it.
Often, yes, because its benefits can diminish over years, and managing the side effects and fluctuations becomes more complex.
So what else can be used maybe earlier on to put off needing LSD? Dopamine agonists.
Dopamine agonists are an option. Drugs like pramipexole, ropinirole, or the injectable apomorphine. They mimic dopamine by directly stimulating the dopamine receptors.
Bypassing the need for conversion?
Right. They can be effective for motor symptoms, especially tremor and rigidity. Apomorphine is very potent, fast-acting, often used as a rescue therapy for sudden off periods.
But downsides?
Agonists can have significant side effects, too. Sometimes different from LC impulse control disorders are a known issue with some, like gambling or hypersexuality. Nausea, hallucinations, sleepiness are also common. Apomorphine carries risks like respiratory depression.
Okay. What about MAO-B inhibitors like selegiline or rasagiline?
These are often used early, sometimes as initial monotherapy. MAO-B is an enzyme in the brain that specifically breaks down dopamine.
So inhibitors stop the breakdown.
Exactly. They help conserve the dopamine that's still being produced, making it last longer. This can provide mild symptomatic benefit and, crucially, delay the need for levodopa.
But there's that important interaction warning, tyramine.
Yes, a critical point. Patients on MAO inhibitors need to avoid foods high in tyramine-aged cheeses, cured meats, some wines, certain beans. Consuming tyramine can cause a dangerous hypertensive crisis.
Wow. Need careful dietary counseling.
Absolutely. And interactions with certain antidepressants like SSRIs or tricyclics are also a concern, potentially leading to serotonin syndrome. Medication lists need careful review.
All right. Now, for dealing with that wearing off of levodopa later on, you mentioned COMT inhibitors, the MAPONE drugs.
Right. Anticapone and tolcapone. COMT is another enzyme that breaks down levodopa, mostly in the periphery, but tolcapone works centrally too.
And these are always given with LC.
Always. They have no benefit on their own. They act purely to block COMT, which extends the duration of action at each levodopa dose. They help smooth out those fluctuations and reduce off time.
Making the LC last longer between doses.
Exactly. Just a note. Tolcapone requires regular liver function tests because of a risk of liver toxicity, so entacapone is often preferred.
Okay, Parkinson's isn't just motor symptoms. Cognitive issues and psychosis can be major problems too.
Huge problems, especially later on. Hallucinations or delusions can affect up to half of patients. Standard antipsychotics are usually avoided because they block dopamine and worsen motor symptoms badly.
So specific agents are needed.
Yes. Drugs like pimavanserin were developed specifically for Parkinson's disease psychosis and for the cognitive decline or dementia that often develops.
You borrow drugs from Alzheimer's treatment.
We do. The first group are the acetylcholinesterase inhibitors, like rivastigmine, which is available as the Exelon patch.
How do they help in Parkinson's dementia?
They block the breakdown of acetylcholine. While Parkinson's is primarily a dopamine problem, Boosting acetylcholine seems to help with attention and cognitive function in dementia associated with the disease.
The patch is helpful for administration.
Very helpful if someone has trouble swallowing pills. These drugs are considered first line to try and slow cognitive decline, but the benefit is usually temporary, maybe for 1 to 3 years. Side effects like nausea, vomiting, diarrhea, and sometimes depression or liver issues can limit use.
And the other option for dementia is memantine.
Yes, memantine. It's an
Right.
NMDA receptor antagonist. The mechanism in dementia is complex, but it's thought to protect neurons from damage caused by excessive glutamate stimulation, which might play a role in neurodegeneration.
The same receptor involved in excitotoxicity after stroke.
The very same. Interesting connection. Clinically, memantine is used for moderate to severe Parkinson's dementia, often added to an acetylcholinesterase inhibitor. It's generally better tolerated, fewer GI side effects, though dizziness or confusion can occur.
Mm.
Hashtag tag outro.
Wow, that was an incredibly detailed journey. We went from the absolute brink total energy failure in the brain within minutes through the secondary damage cascades like excitotoxicity, the mechanical nightmare of ICP,
Right, the pressure cooker effect.
and then all the way to these incredibly specific, nuanced drug strategies needed for a chronic disease like Parkinson's, trying to fine-tune those neurotransmitter levels.
And what's really striking, I think, is how the underlying mechanisms often overlap, whether it's acute trauma or slow degeneration. Things like energy failure, calcium overload, enzyme activation. They're common pathways to cell death.
So understanding the acute injury helps us find targets for the chronic stuff.
It really does. The fundamental physiology guides the treatment no matter the timescale.
We saw how fast the brain collapses when pressure gets too high or blood flow stalks, but then we dove deep into autonomic dysreflexia, a crisis triggered not by the brain failing, but by the spinal cord, launching this massive, automatic, life-threatening reflex to something simple, like a full bladder that the person might not even feel.
A complete physiological short circuit, bypassing brain control.
Yeah. So the provocative thought for you, the listener, what does that massive overreaction tell us about all the hidden involuntary systems constantly running in our bodies? Systems maybe just one small, unnoticed trigger away from potential crisis. What else might be going on below our conscious awareness, compensating, maybe even overriding, ready to cause chaos if the wiring gets crossed?
Definitely something to ponder. The body's hidden regulators.
Think about that paradox of control and chaos until our next deep dive.